This is a lecture on seizures. A seizure is caused by an abnormal excessive hypersynchronous discharge of CNS neurons, and it's characterized by a sudden transient alteration in brain function. Depending on the distribution of discharges, this abnormal CNS activity can result in various manifestations involving motor, sensory, autonomic, or psychic clinical manifestations, and an alteration in level of arousal. The alteration in LOC is temporary. The term convulsion is sometimes applied to seizure and refers to the tonic-clonic or the jerky contract-like or contract-relax movement associated with some seizures. In terms of etiology, anything or any condition that changes the environment around a nerve can produce a seizure. So in theory, anyone can have a seizure. In reference to types of seizures, partial seizures are known as focal seizures, and they involve neurons only unilaterally. They often have local or a focal onset, and they originate from the superficial areas of the brain. They have subtypes, three subtypes. One is a simple without loss of consciousness, and that means that it's confined to one hemisphere. So again, LOC is not lost. Then there's the complex with LOC. So that means that it begins in the temporal lobe, it spreads to both hemispheres. Consciousness is definitely lost. Then there's secondary generalization. Consciousness is lost with that one as well. Then there's your generalized seizure. That involves neurons bilaterally. Often they do not have a local or a focal onset. They usually originate from a subcortical or deeper brain location, and they may result from cellular, biochemical, or structural abnormalities. Consciousness is always impaired or lost. In terms of types of generalized seizures, you have an absence or simple petit mal, whereby the person has a staring spell. It usually lasts less than 15 seconds. The person is unaware of his or her surroundings. With an absence atypical, you have a staring spell that's accompanied by myoclonic jerks and automatism, such as chewing and smacking of the lips, and you have an atypical spike wave pattern on the EEG. For myoclonic kinds of generalized seizures, there's a single jerk of one or more muscle groups lasting only a second. Atonic, you have what's called a drop attack. Drop attack means atonic. Um, so you have astatic or akinetic kinds of movement. Sometimes that's associated with myoclonic seizures. It's characterized by sudden loss of posture, and if it's mild, the person may just have a head nod, but if it's dramatic, the person will fall. With clonic seizures, there's jerking of muscle groups. With tonic, there's stiffening of muscle groups. And with the tonic-clonic grand mal, or what used to be called grand mal, you have an issue with it starting with the tonic or stiffening phase. So you have violent rhythmic contractions followed by clonic or jerking phase. There's unconsciousness, there's possible bowel and bladder incontinence, and the person may bite his or her tongue. At the end of the clonic phase, the person may remain unconscious until the RAS begins to function again, or they will remain unconscious, pardon me, until the RAS begins to function again, and that is called the post-ictal phase. Symptoms of confusion and sleepiness are present during the post-ictal phase, and there's no memory of the seizure. There's also what's called your metabolic or toxin-induced seizure activity. It's usually generalized, and it usually does not recur as long as the underlying cause remains corrected. In terms of the patho for seizures, you have a membrane defect that leads to instability in the resting potential, abnormalities in potassium conductance, defects in GABA, inhibitory system, or an abnormality in NMDA excitatory system. That leads to high frequency bursts of action potentials in hypersynchronization produced by a long-lasting depolarization of the neuron caused by an influx of calcium that opens the voltage-dependent sodium channel. As a result, you have influx of sodium that generates repetitive action potentials, and as a result of that, you have firing of neurons. You have an increase in frequency of them and increase in amplitude. So then two things occur. You have, with sufficient neuronal activation, neurons in the surrounding area become recruited, and then you have the discharge that spreads to adjacent neurons. Therein lies your generalized seizure. So you have muscle contractions, and LOC is lost. Now, meanwhile, you have this excitatory issue going on. You also have inhibitory neurons that slow the firing and cause interruptions of the seizure, and this is how you get the tonic-clonic part of it. The maintenance of a seizure activity demands 250% increase in ATP. And with cerebral blood oxygen consumption, that is as much as, it increases as much as by 60%. So although cerebral blood flow increases approximately 250% during seizure activity, available glucose and oxygen are readily depleted, and as a result, there's a deficiency in ATP, phosphocreatine, glucose also occurs, and therefore lactic acid accumulates in the brain and cellular exhaustion occurs. When you have seizures that do not stop spontaneously, or they occur in succession without recovery, that is called status epilepticus. You have a prodromal period and also an aura. Those occur prior to seizures. So with the prodromal or warning sign that a seizure is imminent, the patient can have either a headache, be lethargic, have epigastric sensations, or experience mood alterations, or the patient may have palpitations or myoclonic jerking. These symptoms come on minutes to hours before consciousness is lost. Once the patient recovers from the seizure, he or she is able to recall the warning sign. With an aura, the patient may experience a brief auditory, olfactory, or gustatory signal a few seconds before losing consciousness. And again, the patient recalls this warning sign after recovering from the seizure. This concludes the lecture on seizures. If having questions, please contact me at halef@hawaii.edu.